Welcome everyone to the first of a six webinar series on cirrhosis care, practical tips you can use in your practice today, brought to you by the Office of Lifelong Learning and Physician Learning Program. I'm Denise Campbell-Scher, I'm the Associate Dean of the Office. We here at the Office of Lifelong Learning and Physician Learning Programs are committed to bringing you the latest information, advice, and resources related to cirrhosis care for physicians and other healthcare providers. We're very pleased that tonight Dr. Juan Abraldes will be joining us to kick off the series. And I'd like to acknowledge that we are on the traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. So it's my very great pleasure to introduce you to one of our medical directors, Dr. Punita Tanit. Punita is an associate professor of medicine and co-director of the Cirrhosis Care Clinic and a transplant hepatologist at the University of Alberta in Edmonton, Alberta. So I'm going to turn it over to Punita.
Thanks, Denise, and thank you to everyone for coming to our first of an amazing series of lectures. So I am so happy to introduce Juan Abraldes, but before I do that, I just want to point out that this series of webinars that we're putting on is to kick off a cirrhosis quality improvement project that we're doing throughout the province. As you can see, there's many interesting topics that are going to be covered over the next 6 weeks, and all of that will be hosted on our cirrhosiscare.ca website, which will come live end of January, beginning of February. So we'll send you more details about that as it becomes live. So Juan Abraldes, on to the star of the show. Juan is a friend, transplant hepatologist, professor, and director of the liver unit at the University of Alberta in Edmonton. He gained his MD from the University of Santiago de Compostela in Spain, and he got his board certification in gastro and hep at the liver unit in Hospital Clinic in Barcelona. He did his postdoctoral training at Yale University, and he was a faculty member at the liver unit in Barcelona until 2013, when we got him to thankfully move here to be with us in Edmonton. And Juan, for any of you who know him, is incredible. He's published over 200 papers on pathophysiology, diagnosis, and management of cirrhosis. He's a co-author of the American Association for Liver Disease Clinical Guidance for the Management of Varices and Variceal Bleeding, and certainly hands down one of the most brilliant people I've ever met. So thank you, Juan, for giving the inaugural lecture in this series.
Thank you very much, Punita. As you can imagine, Punita is a good friend, so that introduction was a reflect for that. In fact, Punita is responsible that I left Barcelona for Edmonton. So you can imagine that she has a very important influence in me. Okay, so today I thank you all for joining in an evening. And I see some people from the East Coast, so even later than 7 p.m. And I will talk about how to answer the question, does my patient have cirrhosis? These are my conflicts, not too many. And the agenda will be this. I will talk what is cirrhosis, what are the causes of cirrhosis, what are the main complications of cirrhosis, how does cirrhosis cause complications? So that will be some pathophysiology primer. And I will talk about cirrhosis in the asymptomatic patient. Does it matter? Because I'm always very worried to put a label, and a label such as cirrhosis that is so distressing to a patient that has no symptoms. But I will show why this is important, and if it matters, how we diagnose cirrhosis in an asymptomatic patient. So I will put two clinical scenarios to start. The first clinical scenario is a male patient of 60 years old, previously asymptomatic, little contact with healthcare system, presents with abdominal swelling in the last 3 weeks, with distension that in fact causes pain, and has no edema, no shortness of breath, no signs of GI bleeding, no history of confusion, no alcohol use. He tells us that he used few times heroin in the 80s. Her labs are not that impressive, bilirubin 15, albumin 30, AST 50, ALT 30, platelet count 70. INR 1.3. On examination, he's oriented, BMI is 26, blood pressure is on the low side, normal jugular pressure, no hepatomegaly, mild splenomegaly, no abdominal collateral circulation, no edema, and no asterixis. The ultrasound shows a nodular liver, a pedal portal vein velocity 12 centimeters per second, which is decreased, a spleen 13.5, which is increased, and moderate ascites. So the question is that this patient has cirrhosis, and I'm going to immediately answer this question because this is, I will say, a completely obvious patient. There are obviously differentials, but I think it is obvious that he has a clinical complication that occurs in cirrhosis, which is ascites. He has a blood work that suggests cirrhosis because the AST to ALT ratio is high. His blood work suggests not only cirrhosis, but also portal hypertension because he has a low platelet count. The ultrasound suggests that he has cirrhosis because he has a nodular liver and he has signs of portal hypertension. And he has a risk factor, and he probably has, I will say that the probability that this patient has hepatitis C is very high. So this is an obvious patient. I will go to the second case, which I think is much less obvious, and I think which is the focus or the topic of this talk. A male patient, 60 years old, asymptomatic for routine follow-up of his metabolic syndrome. He has diabetes on metformin, obesity, with a BMI of 35, hypercholesterolemia and statin, high blood pressure on ramipril. He does not take alcohol. He has no history of IV drug use. He has the following labs: bilirubin that is normal, albumin that is normal, AST 50 that for an Alberta lab is normal, ALT 30, platelet count 150, and INR 1.0. And thus this patient has cirrhosis. I think is a very important question that we will address in the next 30 minutes. And if he has cirrhosis, does it matter? So what is cirrhosis? Cirrhosis is the final pathway for many chronic liver disease. When you have chronic inflammation and a chronic insult of low grade to the liver that is maintained for years, you have injury repair mechanisms that leads to fibrosis and regenerative nodules. And this is the fibrosis process. We classify F1, F2, F3, and F4 as progressing fibrosis, and F4 is what we call cirrhosis, with the typical regenerative nodules and septa that become thicker and thicker as cirrhosis progresses. The first concept that I have to emphasize is that you diagnose this traditionally with a liver biopsy, which is only 1 out of 50,000 of the volume of the liver. So it's very difficult to differentiate when you do a biopsy. You are not one day F3 and the next day F4. There might be different areas of the liver in different times of evolution. So it's difficult to differentiate between F3 and F4. So this is why there is this concept of compensated advanced liver disease that I really don't use that much in clinical practice, but you might see in publications that tries to reflect this transition between F3 and cirrhosis that is very difficult to tease out in early phases. The causes of cirrhosis, there are 3 main causes of cirrhosis: viral, mainly hepatitis C, hepatitis B in some contexts, alcohol liver disease, non-alcoholic fatty liver. And then there are much less frequent causes: autoimmune liver diseases, hemochromatosis, and very infrequent, very rare disorders that you have a list here that we very seldom see. One important concept also is that the patient might have more than one cause of cirrhosis. So sometimes when we find a patient that has obvious alcohol use disorder, he drinks heavily and he presents with cirrhosis, we still drop the test, especially for these causes of liver disease, because it's very frequent that in a patient coexist 2 causes of cirrhosis that potentiate themselves and end up causing cirrhosis. And, for example, for alpha-1 antitrypsin deficiency, we many times forget about that. And then we see many livers that when we take out for explant have alpha-1. Not that it has a major impact on the management of this patient, but to show that many times the patient has more than one factor that contributes to cirrhosis. And this is the natural, the typical natural history of cirrhosis. Cirrhosis has a very long compensated phase. And in fact, this phase might last for 10 to 12 years, and the patient might die with compensated cirrhosis without having decompensation. And then we have a very short phase that once the patient has the first decompensation from cirrhosis, the prognosis dramatically worsens. And in the historical series, the median survival time after the first decompensation was 2 years. Nowadays that we have much better treatments, it's probably a little bit longer, but it's a very short period of time in the natural history of the patients. The first and the most frequent first decompensation in cirrhosis is ascites. Almost half of the first decompensations are ascites. Patient can present for the first time with a bleeding. Patient might die without decompensation from something else. A very frequent complication of cirrhosis is liver cancer that might occur as the first presentation of cirrhosis in a compensated patient. Hepatic encephalopathy is very infrequent. It's more frequent as a second complication of cirrhosis. And then we have this area of further decompensation that once the patient decompensates for the first time, keeps having decompensation and develops recurrent hepatic encephalopathy, refractory ascites, spontaneous bacterial peritonitis, and hepatorenal syndrome that are late events in the natural history of cirrhosis that will be dealt with in other webinars of this series. A pathophysiological primer to understand why these complications occur, I think is very important to understand the treatments. So cirrhosis starts with that fibrosis, regenerative nodules that increase the resistance to portal blood flow. So this causes an initial increase in portal pressure. But once this initial increase in portal pressure occurs, there are a series of changes in the splanchnic circulation, and this is mainly splanchnic vasodilation, that since the splanchnic vasculature is around 30% of the systemic vascular resistance, so that causes hypotension and causes arterial underfilling. The vases are so dilated that the plasma volume that we have does not fill the circulation. So this causes effective hypovolemia and activation of neurohumoral systems such as the renin-angiotensin system, and non-osmotic secretion of vasopressin, and this retains sodium, water, causes hypervolemia, causes an increase in cardiac output that together with this vasodilation and increase in cardiac output increases the flow that goes through the system. And this, since the pressure is resistance times flow, this aggravates portal hypertension and maintains portal hypertension despite the system develops escape routes with portosystemic collaterals that decompress in part of the system, but since the system is increasingly continuously fed, this maintains portal hypertension. So portosystemic collaterals cause variceal bleeding and encephalopathy because the blood bypasses the liver and is not cleared from ammonia. The sodium and water retention and hypovolemia together with the increase in pressure causes ascites. And when these events are extreme, there is extreme activation of these vasoconstrictor systems that vasoconstrict the renal arterioles and decrease the GFR and cause a kind of prerenal situation due to arterial vasoconstriction that we call hepatorenal syndrome. So you see that the patient starts with one disease, which is cirrhosis, but then ends up with a kind of a multi-systemic second disease, which is the whole portal hypertension syndrome. And this obviously does not occur in a vacuum. It occurs in a patient that if he has increased liver injury, develops progressive liver failure. But sometimes you don't have liver failure. We see patients that have ascites and have very severe complications, and bilirubin is completely normal. So the portal systemic syndrome predominates. In other patients, the liver failure predominates, for example, in patients with alcohol-associated hepatitis. So understanding this is important to understand, for example, that vasodilation is at the center of all these pathophysiology. So when patients with cirrhosis decompensate, we have to stop the vasodilators. They normally decrease their blood pressure, so they don't need anymore any kind of medications for blood pressure most of the times. And that non-selective beta blockers improve the portal systemic syndrome because non-selective beta blockers have a beta-2 effect that produces plaque vasoconstriction and have a beta-1 effect that decreases cardiac output. So it decreases the flow component of portal hypertension and decreases portal pressure. We don't have any medication to improve liver failure. We only have etiological treatments, and by treating the cause of the liver, there is normally, not always, but normally an increase in liver function. Etiological treatments, we have hepatitis C. We cure now almost 100% of the patients with hepatitis C, even at advanced stage, and this improves the prognosis of cirrhosis with hepatitis C. Hepatitis B, we have medications that do not cure hepatitis B, but suppress the replication. Alcohol, we have the treatment of alcohol use disorder, and probably alcohol is the most reversible chronic liver disease. And even if cirrhosis does not reverse most of the times, the patient completely recompensates, and a patient that we will see jaundice with ascites and variceal bleeding 20 years down the road might have a completely normal liver function if the patient abstains and survives that initial life-threatening episode. And this is important to tell the patient because that clearly motivates them to abstain. That is the most reversible liver disease. NAFLD, we only have weight loss. We don't have treatments nowadays specifically for NAFLD. Probably they will come soon. Autoimmune hepatitis, immunosuppressors, hemochromatosis, phlebotomies, and Wilson's copper chelators. Etiological treatments have a marked effect on the natural history of cirrhosis, but very rarely achieve cirrhosis regression. And this is important because that means that the risk of liver cancer, even in patients, if patients normalize liver function, if they have cirrhosis, persists in the long term. So I will not talk about, I have mostly talked about the complications of cirrhosis, but I want to talk about that long phase in which the patient is asymptomatic, whether it matters, and if it matters, how do we diagnose that? And this is the typical history of the second patient that I talk about. Cirrhosis, putting the label that a patient has cirrhosis is important mainly nowadays for three reasons if the patient is completely asymptomatic. Because cirrhosis triggers the initiation of ACC screening, and doing screening for hepatocellular carcinoma with ultrasound every 6 months decreases the risk of finding an untreatable HCC. So not only is a program of screening that really gets more patients at a treatable stage, does not only prolong the time of patients with cancer. The detection of cirrhosis is the patient has what we call clinically significant portal hypertension. If we treat them with beta blockers, we decrease the development of complications of cirrhosis, mainly of ascites. And if we detect cirrhosis and the patient has esophageal varices, especially large varices, we can prevent variceal bleeding even either with beta blockers or with variceal ligation. So there is kind of a nihilist vision that, if the patient has no symptoms, we should just wait for the patient to have the first complication to put him the level of cirrhosis. But if we diagnose the patient much earlier, we can do things to prevent the progression in the natural history of cirrhosis. Things that are simple and have a major impact of prognosis. So we need an operational definition of cirrhosis for the patient, like patient number 2 that had no clinical signs of cirrhosis, had blood tests that even didn't look like he had cirrhosis, we need to find a way of defining cirrhosis. And this cannot be biopsy, because we cannot biopsy a large number of patients. It's completely impractical and has a sampling error. We are only testing 1 out of 50,000 of the liver. We can do ultrasounds, and in ultrasounds, we find a nodular contour of the liver, or we find collateral. So we have decreased velocity of the portal vein that has a very high positive predictive value for diagnosis cirrhosis. But not finding these things has a very low negative predictive value. So we have many, many patients with cirrhosis that have just irregular contour, or the ultrasound is reported as normal. So we need something else. And something else came with a revolution that I can tell you that, for example, in my career occurred in 2008, and here in Edmonton occurred also in 2008, which was the development of non-invasive methods to detect fibrosis, and the first one was FibroScan. I'm going to talk first about FibroScan. And this was something that, as a curiosity, that this is probably the first paper assessing ultrasonics to assess chest maturity. And this was done in Valencia, in Spain. And then it was also used to check the maturity of the meat. I will put this video, and it works. This is the FibroScan machine that sends a vibration to the liver. So I will start again. This is a normal liver, and the normal liver is like a sponge. So you send the mechanical vibration and it goes very slow. This is a cirrhotic liver that you see the vibration goes much faster. This is slow in a smooth liver and very fast in a stiff liver. This has completely changed. This simple idea has completely changed how we practice hepatology in the last few years. This is what we call the elastogram, that this wave goes very slowly. This goes a little bit faster. This goes very fast. So stiffness 3, 7.7, some fibrosis. This was normal, and this is typical of cirrhosis. So before 2008, we were doing, in my unit, I remember 15 or 20 biopsies per week. And then after we had this tool, we decreased that to 2 or 3 biopsies, liver biopsies per week in outpatients. So it has revolutionized how we practice hepatology. FibroScan is not the only technique, was the first, but there are other techniques to assess elastography. And here you can order an elastography, what we call a shear wave elastography. That is a different technique. Rather than putting that giving an external mechanical stimulus, it gives an acoustic stimulus with ultrasound machines and an acoustic wave, and you see how fast this acoustic wave goes. There is 2D shear wave elastography, which most of the machines in Edmonton is what they do, that you see that you have here an area, or point shear wave elastography that is like along a line. Okay, so we are trying still to understand how these new machines relate to FibroScan, because most of the literature associating elastography with clinical outcomes have been done with FibroScan. So this is a study that took 2D shear wave elastography machines and compared with FibroScan, and you see that the results are mostly similar. Unfortunately, none of the machines that we use in Edmonton are either of these 2 machines. With point shear wave elastography, they tested 4 different machines, and one was almost similar, but 3 were not that similar. So it's very important that before we apply what we know from FibroScan to the results of shear wave elastography, that we understand a little bit better what the numbers that we get from shear wave elastography means. The last elastography technique that has been around also for some years is MRI elastography. Has the advantage that it interrogates the whole liver. You know, you put the patient on the MRI, there is this device that induces, again, a mechanical vibration, and you check with MRI the images in the liver, and you can test the whole liver. That's a big difference with the other techniques. But is a completely different scale. The numbers is very time consuming, and we have low access. To give you an idea, we can do approximately between 2 and 4 per week, whereas we do approximately, I don't know, maybe 200 FibroScans a week. So one of the, talking about FibroScan, is important to understand how do we hepatologists use FibroScan. And, you know, we have this kind of plots in clinic in which we have, you know, what is F1, F2, F3, F4, and the transition. We have here the etiologies, and, you know, we look at the number and we can assign F2, F3, and all that, but we really not, we do not use like that. We do not measure a FibroScan. We get an 8 and we say it is F2. This is not how we use this. We don't use this like this because of this. This is a study that was one of the first studies that, and I had the opportunity to participate with an Italian group, and we look with biopsies and FibroScan. And as you can see, this is the distribution of patients according to the biopsy. What you can see is that you cannot differentiate with FibroScan F0 from F1. With F2, you start to have higher values, but the overlap between F0, F1, F2 is huge. With F3, you start to have a clear separation. But as you see, there is an area between probably 12 and 18 that it can be either F4 or F3. And F4 clearly separates from the others. And as you can see, practically, it's extremely unusual to find a patient with cirrhosis that has a FibroScan of less than 12. So as I say, we don't see a FibroScan of 8 F2. What we use, how we use FibroScan is that we have like blocks of values, and we make clinical decisions based on that block of values. So if we find a FibroScan of less than 8, we say the patient is low risk, nothing bad is going to happen to that liver. If we have a FibroScan between 8 to 12, we know that there is something going on. There is probably fibrosis going on, but the chances of having cirrhosis are negligible. Less than 12, negligible chances of finding cirrhosis. Between 12 and 16, this is where it can be cirrhosis or not cirrhosis. Most of the patients are either have cirrhosis or F3, and above 16, the chances of having cirrhosis are very, very, very high. So this is why how we use FibroScan. You know, I never put in a letter, the patient had a FibroScan of 10, so he has F3. I use it as I said here. So what are the clinical relevant thresholds that we use in compensated cirrhosis? We have to stratify this very long asymptomatic phase into actionable items that we can act in the benefit of the patient. So we know that if FibroScan is less than 12, the patient does not have cirrhosis. If FibroScan is more than 16, we know the patient has cirrhosis, and we start for sure ACC screening. And this is in fact the value that the American Gastroenterological Association recommends to start ACC screening in NAFLD. I recognize that they are between 12 to 16, the patient might have cirrhosis, so it's a kind of a personal choice when to start between 12 or 16, the ACC screening. But the guidelines specifically for NAFLD recommend 16. For other etiologies, there is not a clear unified threshold. If the patient has a FibroScan of more than 20 or platelet count less than 150, the patient is at risk of having large varices. So we do an endoscopy to assess whether the patient has varices, and if the patient has large varices, we know that either beta blockers or variceal ligation prevent variceal bleeding, reduce by half the risk of having a variceal bleeding. And if the patient has more than 25, we know that for sure that patient has significant portal hypertension, and these are the patients that, regardless they have varices or not, benefit from beta blockers to prevent decompensation. So in fact, when the patient has more than 25 in my practice, I start beta blockers and I don't do an endoscopy, because if I do an endoscopy and find varices, I would start beta blockers. I only do an endoscopy if the patient has contraindications. So you see that we can really change in a completely asymptomatic patient what is his future in terms of progressing across this natural history to liver cancer. We cannot prevent liver cancer, but we can find liver cancer at a treatable stage. The last thing I want to address is, do we need to do elastography in every patient with chronic liver disease? And can we be more efficient? And this relates to the problem of NAFLD. NAFLD is a huge problem. The typical quote that we hear is that 25% of Canadians have NAFLD. This will be over 200,000 people in Edmonton. Isn't that right? Yes, that's right, 200,000 people in Edmonton. But what we know is that most of these patients do not have a relevant liver disease. They have fatty liver, but we shouldn't even call it a disease. It's just fatty liver is a manifestation of the metabolic syndrome and have no or minimal inflammation, no fibrosis. They have a negligible risk of liver disease. This is very, very well established in many natural history studies. In 5% of the patients, there is some inflammation, some hepatocyte injuries, what we call non-alcoholic steatohepatitis, NASH. So these patients are at a higher risk of progressing to what really matters for liver disease, which is F3, F4, which is only 1% of the population. So we hear a lot that 25% have a silent killer. No, it's not like that. Is that 1% of the population may have silent, very relevant liver disease related to NAFLD. And this is what we have to pick up. But we cannot fibroscan 200,000 patients in Edmonton. We cannot try to detect all these patients, because this is really of very little relevance. I will say that we don't need to tell the patient yet that he has another disease apart from diabetes, for high blood pressure or whatever. We can emphasize that they need lifestyle measures to improve obesity and to have a good control on diabetes and hypertension. So what we use here in Alberta, because it's very simple, is very cheap, is a test called FIB-4 score. FIB-4 score is a combination of age, a modified AST to ALT ratio. AST to ALT ratio you will see in almost every score, either AST by itself or the ratio of ALT to AST, because when fibrosis progresses, AST increases, while ALT does not increase, so the ratio increases. And the inverse of platelet count, so the lower the platelet count, the higher the FIB-4. So this was developed many years ago. It has been shown that both, if you have a FIB-4 or less than 1.3, the likelihood of advanced fibrosis, either in NAFLD, hepatitis C, or alcohol liver disease is minimal. This is very simple to calculate. We are planning to implement that in Connect Care, or even that you can order FIB-4, so it will be extremely simple, but it takes 10 seconds to put these values and get a FIB-4. You just Google FIB-4 and that's it. And this was a study of 64,000 patients in Europe diagnosed with NAFLD. 2/3 of them had a FIB-4 of less than 1.3, and among these patients, over a follow-up of 3 years, only 8 out of 10,000 had a subsequent diagnosis of cirrhosis, and only 3 out of 10,000 had a subsequent diagnosis of liver cancer. So it's extremely safe to triage patients with NAFLD, hepatitis C, or alcohol with FIB4 to exclude the presence of advanced fibrosis. So in fact, this is what we recommend in the NAFLD pathway, a provincial pathway that was developed between primary care and gastroenterology and hepatologists, is that once you have a diagnosis of NAFLD, you re-stratify with FIB4. If it's more than 1.3, you refer to hepatology. What we will do is to do a FibroScan to further re-stratify. And if it's less than 12, we know it's no cirrhosis. And if it's more than 12, we start to suspect cirrhosis, and if more than 16, we start ACC screening, etc., etc. And it's lower than 1.3, the patient goes back to the medical home to have lifestyle modification. So I go back to conclude to the clinical scenario number 2. This is a patient that was completely asymptomatic, had metabolic syndrome, had a minimally abnormal, or if you look at the literality, the 50 will be normal for Alberta AST. But if you put this in the FIB4 calculator, you will have a FIB4 of 3.65, which strongly suggests that the patient might have advanced fibrosis. And the key here is both the platelet count, which is 150 at the very limit of normality, and that ratio of AST to ALT that is increased. That should trigger an alarm. Does it matter? Yes, it matters. Then we did a FibroScan that was 26. And then what do we do with these patients? We treat etiology. In this case, it will be the treatment of obesity, the control of diabetes, cholesterol, high blood pressure. We will do because the patient has more than 16 ACC screening, and because the patient has more than 25, or if the patient had an ultrasound with signs of portal hypertension, we will conclude the patient has clinically significant portal hypertension. We'll start him on carvedilol, and there will be no need for endoscopy. And if he had contraindications for carvedilol, we will do an endoscopy and ligate the varices if there were large varices. So very pragmatic approach, very cheap approach. Carvedilol is extremely cheap medication and decreases by half the risk of decompensation in patients with compensated cirrhosis and portal hypertension by half, which is very few medications decrease by half the risk of something. So the take-home messages is that in patients with chronic liver disease that progress to cirrhosis, they have an increased risk of liver cancer and increased risk of complications. Nowadays, we rarely perform a liver biopsy to diagnose cirrhosis. Ultrasound might show obvious signs of cirrhosis, but absence of obvious signs of cirrhosis does not mean that the patient does not have cirrhosis. FibroScan or vibration control transient elastography, the technical name, stratifies the patients according to the need of ACC screening, endoscopic screening, and beta blockers to prevent decompensation. And we hope that soon we can use shear wave elastography because, FibroScan for now is in the offices of hepatologists or gastroenterologists. Shear wave elastography, it will be great to have access in the radiology offices, but we do have to understand what those values mean. And if FIB4 is less than 1.3, it can be used to pre-triage patients with NAFLD, and alcohol or hepatitis C that do not need elastography measurements. I conclude with this that was put by Punita Tandon and her team, which is the Cirrhosis Care Alberta website, cirrhosiscare.ca. That is, I understand it's not yet on, but it will be on probably the beginning of February. That has an amazingly curated information, very practical for the management of cirrhosis. And really, thank you very much for giving me the opportunity to talk tonight. Thank you.
Thank you so much, Juan. So Punita will have you come back and just for everyone who's participating, just a reminder that you can put questions in the Q&A box. And we have some that have already been kicking us off. So Jane is asking us about the FibroScan and how long is it valid for? So if you've done it once, when should you think about re-stratifying them again? And is there any sort of guidance about what interval might be appropriate?
That's a very good point. When FibroScan is, let's say it's less than 8, so you are very sure the patient doesn't have a relevant fibrosis. In fact, what we recommend for is risk stratifying is to repeat FIB4 every 2 to 3 years. We don't specify 2 to 3 years, 2 or 3 years in the NAFLD pathway, but every 2 to 3 years is reasonable to remeasure FIB4. When you have a FibroScan, let's say that you have a patient that has advanced fibrosis and have a FibroScan that is, let's say, 13 and does not reach the limit either for ACC screening or variceal screening or treatment of portal hypertension, then we'll repeat that every year, at least in our patients with cirrhosis. In patients with compensated cirrhosis, we see them normally. We ask for an ultrasound every 6 months, and we have now a recall system that works very well. And we normally see those patients every year because the chances of decompensation are so low. And if they decompensate, then we will see when they decompensate. So we repeat normally the FibroScan every year until they reach the thresholds. Once they have a threshold of FibroScan of 26, then we don't need to repeat that because the patient is already there needing treatment for portal hypertension. And obviously in patients with decompensated cirrhosis, we don't do FibroScan because they already have advanced cirrhosis with complications. So it does not answer any question that we might have.
Thank you. And Cynthia's got a couple of related questions. So I think it was a bit of a change. She said, so you don't ban for primary prophylaxis. And then she asked also, how would you assess your beta blockade is effective?
Sorry, the first question I did not get. For primary
she was wondering about with the esophageal varices, I think, so about
okay.
banding.
Yes.
And if you chose to use the beta blockade, how would you be confident that it was working?
Yes, so the trials showing a benefit of beta blockers versus placebo or beta blockers versus variceal ligation for the prevention of variceal bleeding or for the prevention of decompensation were done in that you take beta blockers and you titrate against heart rate. It's true that this what happens with heart rate does not reflect what happens with portal pressure. But obviously, we don't measure portal pressure in clinical practice, except in very, very narrow context, mainly for the differential diagnosis. But in clinical practice, we take a patient, we give beta blockers, and we try to titrate those beta blockers. If we use propranolol or nadolol to decrease the heart rate to 55 to 60, provided that they not cause hypotension. With carvedilol, we do it slightly different. We just start carvedilol, maybe depending on the initial blood pressure, either 3.125 BID or 6.25 BID. And then we target a maximum dose in compensated patients of 25 milligrams per day total. So that will be 12.5 BID. Mm-hmm. And this has shown in trials, regardless, we don't really, we cannot know whether the portal pressure decreases. What we know is that in randomized trials, this has shown to improve prognosis.
Okay. So Carrie is asking whether there's any guidelines for family doctors to do screening for NAFLD or other liver diseases.
That's a very important and controversial question, and we have when we discuss this with primary care, with hepatologists, there are so many different visions. Currently, the European guidelines recommend to screen for NAFLD in patients with risk factors, mainly with type 2 diabetes. The American guidelines do not recommend to screen for NAFLD in patients even with risk factors. The diabetes guidelines in North America recommend to screen for NAFLD in patients with type 2 diabetes. So it's unclear. They are not clear guidelines for that. In our NAFLD pathway, after several discussions and back and forth, we concluded that the entry to the pathway was going to be abnormal transaminases or the finding of a fatty liver in an ultrasound done for whatever reason.
Mhm.
So my personal view is that if I see a patient with an AST of 50, I will suspect that there is some liver disease, even if the normal values that we have for Alberta is now I think it's up to 55 or to 60. In men more than 40 and in women more than 30, the transaminases are normal. So that will clearly raise my attention. I think we can suggest to do case finding in these patients that are high risk of NAFLD. But for implementing a screening program, the level of evidence that you need is very high. For implementing colon cancer screening, population screening for colon cancer, there has been randomized trials suggesting an improvement in mortality. So there have been no trials to suggest even the case finding in diabetes improves overall outcomes. Since we have such easy tools like FIT4, I think it could be reasonable.
Mhm. Fascinating, thank you. So Zoe has a question about, with regards to portal hypertension, is it determined on FibroScan or how? And then just to clarify, if they're on a beta blocker, then there's no need for a gastroscope, which I think you just clarified, but just to be sure about that.
Yes, there is some association between a FibroScan and the degree of portal hypertension. It's mostly then below some levels of FibroScan, you don't have significant portal hypertension, and above certain levels, you know that you have significant portal hypertension. Then the association is not linear for sure, but we can use those thresholds. We know that below 15 of FibroScan, the chances of significant portal hypertension are very low, and above 25 are very high. This is why we use above 25 to determine that the patient has clinically significant portal hypertension. And then the question of whether in a patient that is on beta blockers, you need an endoscopy or not. So this is a controversial question that we even have among gastroenterologists and hepatologists. But the primary prophylaxis for a first variceal bleeding in patient that has large varices is either beta blockers or pandem ligation, and we don't recommend to combine both. So if a patient is on nadolol or propanolol or carvedilol, which are the 3 beta blockers that have demonstrated to decrease the risk of variceal bleeding, if I do an endoscopy and see large varices, I do not do variceal ligation. So if the patient doesn't have other indication for doing endoscopy, I don't do an endoscopy because I will just keep doing the same. And in that way, I avoid one procedure that is not very invasive, but is, you do sedation, you have to bring the patient to the hospital. And I think the guidelines support the notion that if the patient is on beta blockers, you don't need to do endoscopy.
Thank you. So Andrew's following up with that with a question around if you have a patient who has NAFLD and does have systemic hypertension, would you recommend choosing carvedilol for their blood pressure management to try to prevent the onset of portal hypertension?
We don't know if in patients that do not have cirrhosis or do not have portal hypertension, giving carvedilol prevents the development of portal hypertension. What we do know is that in patients that already have portal hypertension, giving carvedilol decreases portal pressure and prevents complications. So my practical advice, I don't think carvedilol is the first time treatment for high blood pressure. And I think especially in patients with diabetes, there are alternative medications that probably have more, and you know better than myself, what are the first line medications. So my recommendation will be that only in patients that have cirrhosis and then have portal hypertension, in these cases, I always, sometimes I do it myself, sometimes I send a letter suggesting to the family doctor, I think this patient will clearly benefit from carvedilol. The patient has high blood pressure. So please try to put carvedilol in the treatment regimen for his high blood pressure. That is the case. But for patients that do not have significant portal hypertension, it's unclear whether starting at that point carvedilol prevents the portal hypertension, because the basis for action of beta blockers are mainly that decrease in the portal blood inflow that occurs a little bit late in the stage of cirrhosis. You have to really have that increased resistance because of fibrosis, then you have an initial increase in portal pressure, and then you have an increase in portal blood flow. Then is when beta blockers work, which is more or less when FibroScan is more than 25.
Mm-hmm. Excellent. Okay, thanks. So Sanjay is asking nowadays whether there would be any patients that you would want to do a liver biopsy on to establish diagnosis of cirrhosis. Is there any special cases where that would be something you'd still be doing, or do you just not do that anymore?
You know, for determining whether the patient has or does not have cirrhosis, only if they are very equivocal results in tests and the clinical picture is confusing, or they are potential competing etiologies that you don't know, because some patients with NAFLD have positive autoantibodies and have quite high transaminases. Most of the times they are just NAFLD and there is no component of autoimmune hepatitis, but we don't know. So I will say that it's mainly in patients with equivocal findings. Let's say that they have a morphology of in ultrasound that looks cirrhosis, and then you do a FibroScan and it's normal, so they are discrepant results, or when they are when the etiology is unclear. That will be the two clinical scenarios in which we will do a biopsy. But the reality is that I think for that indication, I request a biopsy once a month, and no more than that.
Okay. So Noosh is very patient, actually was the first one asking a question, and says, thank you so much for the fantastic presentation, and wants to ask if elastography can differentiate between fibrosis due to cirrhosis or from other liver infiltrative processes.
That's a very good question, because there are some infiltrative processes that do not exactly reflect, carry on with fibrosis, but increase the liver stiffness. What we measure with the elastography is the stiffness of the liver, which is the consequence of fibrosis. But you can reach an increased liver stiffness by, even if you don't have fibrosis, by other reasons. For example, if you have liver congestion, for example, the heart is not pumping very well, so there is accumulation of blood in your liver because the heart does not pump, that will increase the liver stiffness. If you have an obstruction of the bile ducts, that will put a lot of bile into your liver and will increase liver stiffness. There is no fibrosis there, or with time there might be. So any infiltrative process that increases the liver stiffness will increase FibroScan. So FibroScan mainly has, in some cases, false positives that you can easily identify, because you can see whether there is biliary obstruction, right heart failure, or an ultrasound that shows an infiltrative process. And it really has false negatives, because almost anything that is going on, even inflammation within the liver, will increase liver stiffness.
Mm-hmm. Excellent. And there's a related question I think, Punita, you're going to tackle from Hirsch around how do you approach discordant results between FIB4 and VCTE?
Oh no, I just tried to answer another one of Hirsch's questions, but, or sorry, of a different question, but Juan, you can tackle that. Discordant results between FIB4 and FibroScan.
You mean when you have a low FIB4 and a high FibroScan? That situation is very unlikely. It occurs in, I will say, less than, in fact, the negative predictive value of a FIB4 less than 1.3 for a FibroScan of less than 8 is 97%. So truly, there is, if you do to all FIB4 and FibroScan, you will have 3% of the patients that have a FIB4 or less than 1.3 and a FibroScan of more than 8. Then you will have to, if you have already done the FibroScan, I will guide myself by the FibroScan. I think the negative predictive value is so high that, and FIB4 is so safe that I feel safe not doing a FibroScan with a FIB4 or less than 1.3.
Okay. So Carrie was asking, just to clarify, you mentioned 25% of people have NAFLs, and then you said 5% of people have NASH. Are you saying that it's 5% of the 25% group or 5% of the total population?
5% of the total population. So that is 25% of the total population, 5% of the total population, 1% of the total population have NAFLD, NASH, and NAFLD with advanced fibrosis.
Okay, thanks. And Renee is looking for a little bit, just a little summary. So just to clarify, when family docs should be referring to hepatology in people with a question of cirrhosis. So she asks, so if the FIB4, and this would be over 1.3, or if they have obvious nodularity or question of cirrhosis findings on ultrasound, or positive risk factors like Hep C and Hep B, and what else, she's asking.
So I think that is the as I said, I presented the two clinical scenarios that are more common. A patient that has a complication that looks like cirrhosis, so that needs referral for sure, urgent referral because the patient has a complicated cirrhosis, or a patient that has a chronic liver disease that might have cirrhosis or not, that is asymptomatic. So I think she summarized very nicely if FIB4 is more than 1.3, that not means that the patient has cirrhosis. That means that the patient is at a risk of having cirrhosis, but the positive predictive value of a FIB4 more than 1.3 is less than 15% for cirrhosis. What we know is that if they have less than 1.3, there is no advanced fibrosis or whatever. So once it's more than 1.3, then it's when we do the FibroScan and further re-stratify. When there are signs of cirrhosis on an ultrasound or on any imaging test, that requires a referral. And when there is a disease that has a specific etiological treatment, then it has a referral. It's very important to understand the difference between, to see a hepatologist, you don't need to have cirrhosis. There are many, many diseases that do not have cirrhosis, especially, for example, autoimmune hepatitis that requires very clearly the input of a hepatologist or gastroenterologist, of a specialist, because it's a disease that if you do not treat, it can evolve to cirrhosis in a couple of years, and has a treatment that if you treat that, the lifetime prognosis is excellent, and you can prevent the progression of cirrhosis. So that will be more or less my summary.
Okay, perfect. Thank you. And so I think we're getting close to the end. You guys are good for a few more minutes. Juan,
yes.
Anita? So Andrew has a question about just when you're observing patients and they have, what changes in clinical status would make you perhaps want to do a FIB4 sooner than every 2 or 3 years? So perhaps if they start gaining some more weight, or if there was a concern regarding increased alcohol intake, is there anything that would change that frequency that that would trigger you to say, maybe I need to do that a little bit more frequently?
Yes, that's and that is the beauty of FIB-4. That is, you just ask for regular blood test and you will get a FIB-4. So if you are concerned that the patient might not be doing well because he's drinking more heavily than before, then the first thing that you will do will be to send for the patient for blood work, and you will get some transaminases, some CBC, and then you will have the FIB-4. So it's that easy to get a FIB-4 that my answer will be, if the patient is stable, do every 2 to 3 years. If you have any kind of concern, just order a blood test and you will have a FIB-4 for the same price.
Okay. And I think Lucas has an interesting question. If a patient with compensated cirrhosis on an SBB decompensates and develops ascites, would you recommend temporarily discontinuing the beta blocker?
That's a fantastic question. And you ask the hepatologists, and there will be a big debate on that. And when to discontinue beta blockers. So if the patient has large varices and the patient develops ascites, and you think that there is no complications from beta blockers, and the main complication of beta blockers relates to a decrease in blood pressure. As I have tried to show, the cirrhosis is a disease in which blood pressure progressively decreases. And this is what we call the cirrhosis circulatory dysfunction. And this is what drives the sodium retention and the development of ascites. And when the patient develops ascites, obviously he has more severe circulatory dysfunction. So there is a point in the natural history of cirrhosis in which beta blockers become harmful. Because at some point, this decrease in blood pressure and this decrease in vascular resistance is compensated by an increase in cardiac output. So if you give beta blockers, that increase in cardiac output cannot compensate very well. So there is a point in the natural history of cirrhosis when the patient has the more advanced stage, and this is clinically is normally refractory ascites. That there might be a point in which beta blockers might be harmful, and most studies put that point when systolic blood pressure drops below 90, or when the patient starts to develop some signs of AKI or hyponatremia, which really are the hallmarks of that circulatory dysfunction or that stage in which beta blockers start to do harm and need to be stopped. Mm-hmm. If the patient has already developed ascites, so beta blockers failed in that prevention of decompensation, and the patient does not have varices, then I think there is no clear indication for giving any more beta blockers. So we normally say that in every patient that has decompensated cirrhosis for the first time, if you feel that beta blockers are causing too much hypotension, or you see those signs of circulatory dysfunction, hyponatremia, AKI, you should discontinue beta blockers and do an endoscopy and ligate the varices if they are there. Or if the patient has a bad tolerance to beta blockers.
I'm sorry, Juan, what was the last thing you said? Or if a patient has?
Intolerance. So the patient tells, since you gave me this pill, I am very, very tired, and I have impotence, and I have, some wheezing. I'm not the same since you gave me this pill. So it's very reasonable to do an endoscopy, see if the patient has varices, ligate the varices, and discontinue beta blockers.
Well, Juan, Panita, just want to wind up here, but thanks to all attendees and such an excellent presentation.
Yeah, I told you he was brilliant. So thank you, Juan. That was very practical. And thank you for all the questions, everyone. And next week, we'll actually have another superstar who's mentored both Juan and myself, Guadalupe Garcia-Sao from Yale. And so she'll be talking about the top 10 things you need to know if you don't see cirrhosis as often. So obviously that she's always helpful for learning, even if you do see cirrhosis often. So we hope you can join us next week as well. And thank you, Juan. Thank you, Denise. Thank you, everyone.
Yeah, and thank you to all the team in the background for pulling this together as well, to Melanie and Andrea and Badi and the whole team for all the work. So really looking forward to the next one of this series. Thanks, everybody. You'll get these recordings next week, and we'll really look forward to seeing you for the next event.
Thank you very much.
Have a great evening, everyone. Yeah.
Bye-bye.
Bye, everybody.